Right, good afternoon, everyone. My name is Angel Ziya Tian from Soci Hope School of Public Health, the National University of Singapore. It's been a great pleasure to be able to present our study today on enhancing treatment outcomes, mental health, and quality of life for stable people living with HIV in Cambodia. Right, allow me to start with declaring our conflict of interest. The project is guided by the steering committee chaired by NCHAT with engagement of NAA, UNAIDS, WHO, donors, CSOs, and community. Now, giving you some background, at the national level, Cambodia has successfully reversed its HIV epidemic with treatment coverage of at least 80%. Almost all people diagnosed with HIV epidemic were on treatment, and over 60,000 of them have viral suppression in 2022. There's also a strong commitment to work towards a HIV-free society, and Cambodia was recognized in 2017 to have reached the 390 targets, and now it has an even higher goal of reaching the 95% of this target. The goal of our study is to build an effective and sustainable continuum of care model for all stable people living with HIV in Cambodia. And our overall aim is to evaluate the effectiveness of community-based ART delivery interventions comparing to the standard of care on health and well-being. Well, our study in Cambodia were conducted by comparing these two differentiated care models. The intervention is the community-based ART delivery model, in short CAD, involving the community action workers who are people living with HIV to collect prepackaged ARVs from the ART clinic and dispense them to those in the community. In this study, we have 82 CAD groups, each consisting of 25 members. The other group is the control multi-month dispensing model, in short MMD, that was introduced by the National HIV Program in 2017. Participants in this group, they will travel to ART clinics to receive ARVs. Our study is a mixed method quasi-experimental study using structured questionnaires and qualitative interviews, where we expect to contribute to achieving the 395 targets. And today I'll be focusing on the quantitative evaluation. So our data were collected between May 2021 and April 2023. We have 20 ART clinics across the capital city and 9 purposely selected provinces. A total of 4,089 participants completed the baseline survey, around 2,000 in each arm. We have 25% of total that did not complete the endline survey. The most common reason for dropouts was being unavailable during the endline survey. The primary outcome include viral load suppression, retention in care, and adherence to ART, and we have 6 secondary outcomes, including mental health, quality of life, etc. We compare the outcomes at baseline and endline within and between the two groups, using the differences in differences analysis to account for any unobserved differences. So this plot shows the differences in predicted probabilities between baseline and endline in CAD and MMD, whereas the negative percentages indicate a decrease at baseline and vice versa. Across all the outcomes, we can see that the CAD model demonstrated a potentially promising result than those in MMD. To conclude our preliminary findings, overall, the CAD model has demonstrated its potential effectiveness in sustaining both primary and secondary outcomes from baseline to endline, in comparison to the MMD, of course. And for stable people living with HIV, there were positive changes to their physical health status, improved mental health, better adherence, and reduced fear of stigma. For next step, We're planning to revise and finalize the standard operating procedure for CAD model implementation to adopt CAD to the national program to complement MMD for self-sustaining ART groups in the community. And we also want to establish a funding program for the community ART groups and to conduct a follow-up post-intervention study within 18 months to assess a medium to long-term potential impact of the CAD model. Here are some photos during our field work. As the end of my presentation, please allow me to acknowledge advisors from NCHAS and NAA, healthcare teams at the ART clinics, implementing partners, community action workers, and people living with HIV in Cambodia in giving us their support in the implementation of the project, as well as our research team from Ghana, Cambodia, and the National University of Singapore. Thank you.